We're very privileged this year to have Professor Francesco Montosi here from the University of San Raffaele in Milan. I'm sure he's well known to you all. He's editor-in-chief of the European Urology Journal and past president of the ESSM. He's published extensively on the links between the cardiovascular system and sexual functioning, so he's ideally placed to update us on that topic. Professor Montosi.
Thank you very much. Thank you for the very kind introduction. I am delighted to be here today with you. I've seen so many faces of good friends, and I am happy to talk about a topic which has been a significant part of my research years ago, and which I think is still an important area that must be known for all of us who are seeing patients with erectile dysfunction in the everyday clinic. I would like also to bring the best regards of the European Association of Urology to all of you. I'm now one of the adjunct Secretary Generals, and I hope that you will all consider to become members of the EAU, which is now involving members from more than 100 countries, more than 14,000 members. We do a lot of publications. European Urology is clearly our flagship, and you know that Professor Gincatto is today the editor-in-chief of the journal, and something like 10 days from now we should have the new MPEL factor that hopefully will be higher than the previous one. Education is a key issue for the association, with many courses that are provided to members, and there are always many things to learn. And the same thing applies to the scholarship program, which gives the opportunity to many of our younger trainees to go around the world, to go around Europe and see what the others are doing, learning a lot. This is very efficient, and I would stimulate all of you to send in applications. Meetings are important, and the EAU is providing the members with a number of interesting meetings all over the continent and all over the world, and especially the Congress, which I think you all know, 5 Congress days with lots of abstracts, which are very rigorously selected, and indeed it is an excellent opportunity to be educated. And also the social media activity of the association is indeed extremely active, so I think that with this small number of slides I have given you an opportunity to think about becoming a member of the EAU. So this is essentially the agenda I'm going to cover this morning. I'm going to talk about the risk factors which are there when talking about ED and heart disease, the association between erectile dysfunction and cardiovascular disorders, the pathophysiology which is connecting the two areas, and clinical implications. This slide about risk factors is important because of a very simple and practical reason. Whenever in the office you see a man who is complaining of erectile dysfunction and is asking you to be helped with that, if one or more of these risk factors are around, we must think about a possible association between erectile dysfunction and cardiovascular disease prior to thinking that this person is a good candidate for an oral agent, which is certainly the case, but indeed we do have the opportunity to identify hidden heart disorders which can be treated. And in my experience, I had now almost 50 patients or so who came over. They had vascular risk factors. They did come only for ED. We found a bad obstruction of one or more coronary arteries. They were treated and they were cured of that specific thing. So with that being the starting point, what is the association between erectile dysfunction and cardiovascular disease? This, I think, is the paper that probably led to your very nice invitation. Back in 2001 at my place, I had the idea of looking at those who were coming to the emergency room with an heart attack. Very simple scenario. They would be treated by our cardiologist. They would make a diagnosis, angiographically done diagnosis of an obstruction of one or more coronary artery. Then our group would step in and we would look at everything we wanted to know about sexual function in those men. So we found that the prevalence of ED among those patients, again, symptomatic heart attack, emergency room, and then we went in. 50% had ED, which was already well known. However, we found that ED symptoms preceded cardiovascular disorders in the majority of these patients, and the average would be 3 years. 3 years, which you will agree is a long time. Then Vlachopoulos from Athens, who is a cardiologist with a large interest in the area, did something different. So he took patients with vasculogenic erectile dysfunction, completely asymptomatic. He started from the other side. And then he did the angiography on those patients, and he did found a large number of those having, as you may see in this slide, a very clear obstruction of the coronary artery. So we as urologists can do things, cardiologists can also do things. And results which were similar to these two seminal studies were then published in the literature, and this busy slide is just to summarize the idea that there have been many centers being involved in the area. Not only this became quite clear, but also the fact that the severity of erectile dysfunction could be liaised to the severity of heart disease. If you look at the forest plot analysis here in this area, this would be severe ED, mild ED, and these are the causes for admissions in a large cardiovascular department. If ED is very severe, the number of admissions will be higher. So there is indeed an association between the severity of the symptoms of erectile dysfunction and the severity of the cardiovascular issue. Not only the severity, but also the duration of ED. Once again, this is coming from my brother Piero. He's chief of interventional cardiology at the State University in Milan. And he did this study later on that was interesting because he was able to identify the fact that the longer the ED duration, the greater the risk of subclinical cardiovascular disorder and also of the severity of the cardiovascular disorder. So always ask the question, how long have you been seeing your symptoms of erectile dysfunction? If the patient starts telling you 3 years or longer, then a bell is ringing. Think about this. And this is a summary slide, a lot of systematic reviews, again, to tell you that ED overall in the literature has shown to increase the risk of 40% for cardiovascular events, 62% for MIs, 25% for overall mortality, and this is not an issue only of the aging patient in your office, also for the young men. In my practical experience, diabetes, smoking, those two things must always ring the bell. So never forget the heart of your patient when you're seeing an ED person with this specifically clinical scenario. If you look again at the thing from the other side, it is now very clear that the prevalence of severe ED is again a sign of possible very bad disorder within the heart. So again, the more severe the ED scenario when the patient shows up, if you find something at the cardiological level, there is a higher risk of seeing a 2 or 3 vessel disease. So it is not only black or white. It is really how bad is ED in these patients. What is the pathophysiology behind this? It is not so simple. It's not so simple. This is a systematic review done by one of my residents, Giorgio Gandaglio, who is now a superstar in this area. And these are the issues that are playing the game. Cardiovascular factors, androgens, inflammation, endothelial dysfunction, and atherosclerosis. So let's see what we know now. This is the hypothesis that we developed back in 2003 when we decided to write the article and publish the paper I was showing to you before. It is quite simple, quite straightforward. Clearly, there are risk factors determining endothelial dysfunction and flow-limiting stenosis. All vascular beds are affected to the same extent. This is a principle of vascular medicine, and the ED should be considered as a part of the general disorder. This is a cartoon which is making things easier. This would be a coronary, this would be a penile artery, a deep cavernosal artery. It is smaller than a coronary artery. It is smaller than the iliac, and so on. In this way, if the thickness of the wall is this, it can create symptoms at the level of the penis. It will not create symptoms at the level of the heart, because there is still more than 50% of the lumen which is patent. That's very clear. The smaller the artery, the higher the risk that it can get occluded and create symptoms. This is why we would start seeing symptoms in a scenario like this one in a patient at the erectile function level compared to the heart level much prior, much sooner when in our office when talking to our patients. This is why we should consider the association of the two things. However, this is not necessarily true in all the cases. We don't find arteriogenic issues in the penis in all those who have impotency and then also develop heart disease. So the other possible explanation would be the issue related to inflammation. This was studied a lot again in Athens, again by Vlachopoulos, who did find at the end of a number of studies that the ED onset and the severity of the symptoms are associated with an increased expression of markers of inflammation. And the chronic inflammation is one of the etiologies of the pathogenetic mechanisms also of obstruction in the coronary artery. So endothelial dysfunction, chronic inflammation might be a link joining together the two things. Testosterone levels in the pathophysiology of ED and CAD, I think that the testosterone and the androgen effects in the sexual arena remains quite obscure. We know quite a lot, but we don't know enough. It is indeed true that testosterone is falling in the aging population when we see the majority of these patients. It is possible that low androgen levels might represent a common link between ED and coronary artery disease. And essentially, in all the cartoons reported in the literature, when we're trying to pull together all these concepts, the issue of testosterone is always around, but still we don't know enough. What are the clinical implications? And this is to produce some thoughts that can give you some food for thoughts when you're back home. Information. Information is crucial. This is a very interesting paper which is coming from the European Cardiological Association discussing sexual counseling with for individuals with cardiovascular disease and their partners. Essentially, the end of the story is that the patient has a right to know about the association of these two conditions, and there is a need to educate those working in the cardiological arena much more to be sure that they know what they are talking about. You should consider that the whole area of knowledge of this topic started in urology, and which does not make any sense. I would say, to something like 7 or 8 years ago, all the cardiologists would send patients to us asking, is this patient able to take, can he take Viagra safely? But that would be a cardiological question. It is not a neurological question. Now things are changing, and I would say that all the cardiologists in our country know what are the liaisons between the two areas. But indeed, once again, the concept of communicating this information to the physicians and the healthcare professionals is important. What also should be known about the management of an ED patient without a known history of cardiovascular disorders, one can apply the Framingham risk score. This is still not very well done and very well known in the urological arena, but indeed this could give you the opportunity to estimate the likelihood of subclinical atherosclerosis in the patient with ED who is coming to see you. And when a history of coronary artery disease is known, then we know today that the patient coming to see you with erectile dysfunction and the cardiovascular disorders should be included in 3 groups, depending on the type of cardiovascular disorder that he has. And in the next slide, you will understand quite easily. We modified this cartoon a little bit to make it more practical. It is coming from the so-called Princeton Consensus Conference that was held in 2008 in the US, where patients with ED and a known cardiovascular story should be classified in low risk, high risk, and all the others between the two. Low risk, essentially, these are patients who do have some cardiovascular issues, but they are still fit, they can do whatever they want, and there is no reason to concentrate more on their cardiovascular story, and you should start and make the prescription, take care of them to help them in functioning better. The high-risk patients, these do have a significant risk which is related to sexual activity, and they should be sent to the cardiologist, again, before you start treating them for their erectile dysfunction. Essentially, I use this very simple rule. I ask them, are you able to climb 2 flights of stairs without remaining breathless? I would say that the vast majority of patients know if they can do this or if they cannot do this. I learned this rule by Graham Jackson years ago. And so if the patient is telling me I am in troubles if I do that, then my answer would be, then I think that you should go see your cardiologist again to be sure that you are on the safe side, and then you can start resuming your sexual activity. Clearly, we are not talking about a risk of taking a pill. The pill is harmless, and we all know that Viagra was developed thinking about new nitrates. The thing is that with Viagra and the others, our patients will become active again, will expend energy. So can they afford doing so? So the high-risk patients are still somebody that sometimes I do see, and we should keep in mind that rule. And if we are not sure we have a very fit patient in front of us, just tell him to go back and see the cardiologist. This, I think, is the most interesting slide I have in my talk. It is something that has been published 3 months ago in the Journal of Sexual Medicine, and it is talking about a cost analysis. So essentially, the issue here is that if you take all those who have ED and you consider them, if they have risk factors, to be a possible patient with also cardiovascular issues, and you send them all to see a cardiologist, clearly the expense would be huge. However, if you do that, you will find a certain number of new cardiovascular diagnoses. If you treat those, the overall advantage, also in terms of cost, will be extremely significant. So in principle, and this is an hypothetical study which is developed on a model of analysis of cost, it would make sense to send everybody there. So I think that this is a very interesting area for future research. Time will tell, but it made me think a lot when I did read the paper. Again, proceeding off with the management and lifestyle modification, when thinking also about cardiovascular issues, physical exercise, nutrition, weight control, smoking cessation. Is there a proof that these are helping? There is abundance of proof that these are helping all of them, each after each and the other. But is there A which is better than B or C or D? It looks like there is not so much different. These are the studies that over the years have investigated all those modifications. All of them work, both in terms of prevention of erectile dysfunction and prevention of cardiovascular disease. When the results of these studies were pulled together, you see that all these studies were on this side of the forest plot, so all positive, but there was not a significant difference. So I think that this is something that should be discussed with the patient, and if he's able to correct issues like smoking, for example, and start exercising, then probably he will have also a summation effect. And the last part of my talk is really, again, the management of erectile dysfunction and, again, the role of PD5 inhibitors. I think that all of you know the history of sildenafil that was really studied by Pfizer to be a new drug for angina. We know that every single PD5 inhibitors would never exacerbate ischemia or worsens exercise tolerance. You are aware of the famous New England Journal of Study paper at the very beginning of the Viagra experience, where they clearly show that it would have been beneficial to heart function. And so we are quite safe in stating to our patients, if you want to use one of these drugs, you are on the safe side. I also have to admit that I cannot recall an ED patient over the last 3 to 5 years coming to see me asking, can I take Viagra? Is it safe? Can I take Cialis? Is it safe? Those were the classic questions back in 1998, 1999. No longer that would be the case. So all of you can indeed use PD5 inhibitors, and not only that, but if you take, for example, the diabetic arena, Carmine Gazzaruso is a very good diabetologist and sexual medicine expert working in Pavia, close to Milan. He has published extensive literature in very top journals like this one, where he did show that in patients with diabetes and erectile dysfunction, the risk of having heart attacks was decreased. Look at the bold here line, was decreased in those using PD5 inhibitors. So it is suggesting, and there is a signal, that the continuous use of PD5 inhibitors may have a protecting effect on the heart. Clearly, we don't have double-blind randomized trials, so I'm just talking to you about the signals. And so in the diabetes arena, where you do see very bad patients, there is perhaps one more reason to use PD5 inhibitors also in those who do have cardiac issues. Indeed, there are a number of preclinical studies that have shown a reduction of infarct size in animals receiving sildenafil. So overall, I think once again that whenever we are prescribing a PD5 inhibitors in a patient with ED, cardiovascular issues, who is fit, we can do it very safely, and probably the patient will benefit. This is my second last slide, and unfortunately, these are the question marks which are still there, but this is an association which is fostering research, so it's nice to show the question marks that need the help of all of you. Be engaged, be involved, run studies, and the rationale for CVD screening among ED patients. This is a big question, at least as big as prostate cancer and PSA. Can we freely prescribe treatment for ED in patients with cardiac issues? We don't know a lot, for example, regarding injections, regarding vacuum device, and proerectal medications. Are they reducing the risk of C events? Clearly, the main issue is cost. running these studies would cost a fortune, but one never knows if we are able to find the funding. There are indeed areas. And this is my last slide, again back to the EAU, to invite you all to attend the meeting in Munich that will be in March. Munich is a beautiful city, the program is excellent, and so once again, thank you so much for having me here with you, and I look forward to spending this day together. Thank you.
Thank you very much indeed. We'll take some questions. We've got a few minutes. Can I start off with the increasing use of statins, primary prevention, etc.? Is that going to lead to a reduction in ED, do you think, in the incidence of this problem?
This is an excellent question, because as urologists, I think that we should be knowledgeable also on issues in clinical pharmacology which apparently have nothing to do with urology. I'm thinking about statins and the issue of ED and prostate cancer. I'm thinking about metformin and again the issue of prostate cancer, of which you are all aware. I think that there is a very robust evidence suggesting that statins are very useful in those who have risk factors to develop coronary artery disease. So I am strongly in favor of using those drugs. Whenever I see a patient with ED who is showing up with those risk factors, I talk to him about aspirin, I talk to him about statins, and I talk to him about the need of lifestyle issues and having a good GP or a good internist who is able to guide him. So I think it is important for us not to forget those drugs. We must be a little bit internist also.
Thank you. Sachs.
Great talk, Francesco.
Thank you very much.
One of the problems, of course, is in the assessment of the patients and treatment of these patients. Many of these are perhaps seen as non-urological conditions. And one of the problems, of course, is in terms of healthcare frameworks and economics, particularly in this country. Who should be really managing these problems? So, for example, you screen a patient with cardiovascular disease, let's say he's hypercholesterolemic, hypertensive. I mean, one of the problems, of course, is for urologists to deal with this problem. So there seems to be across boundaries between the various specialities. What's your thoughts on that?
I have a political answer, and then I have again my personal answer. When I was president of the European Society for Sexual Medicine, I was representing, in a way, those who considered to be sexual medicine experts. And my battle horse would be at that time, if we want to survive and grow as sexual medicine expert, we should not be only urologists, we should not be only endocrinologists. So this would be a perfect example. As a urologist, we have the opportunity, and this happens, as you know, Sachs, in many European countries, to be the first seeing these patients. So that you must be knowledgeable of things which are by definition outside the field of urology. So you must know a little bit of diabetes, you must know a little bit of hypertension, you must know a little bit of statins and all these things. So this is the political answer to say that as I think urologists are the top sexual medicine experts today, we should feel the responsibility to be seen by the patient as their target where they want to go to be treated, which clearly has nothing to do with the financial implications you are more than correctly alluding to. I think that there are many differences among countries. I think it depends whether you are talking to a patient in a private practice setting or in a hospital setting, and I do know that there are rules, especially considering the reimbursement of what we do, which are creating pathways of care, also if we don't like them, at least in certain countries. So I think it really depends on where you are practicing. When I talk to my residents when rounding patients, and if there is an issue regarding erectile dysfunction, I always make the point, if you want to survive in a world like ours today, it is difficult that you can imagine yourself or knowing only this small of one thing. At least in my country, that would be the case. So I tell them, be open, be curious. You want to know a lot of things about many different areas, and then you will make your final decisions.
Thank you. Any more questions? Okay, well, thank you very much.
Thank you. Thank you very much.
Thank you. So now we're going to veer on to